Our next speaker is Zach Sellers. Zach, I know very well. He comes from my own home institution. He's an instructor in pediatrics who has a focus on cystic fibrosis, and he's going to give us an overview of cystic fibrosis. Zach.
Thank you. Thank you. Thanks to Walter and the organizers for inviting me to talk about a topic that I'm very excited about, and that's cystic fibrosis. So CF is often viewed as a lung disease, and I think this is really a myopic view of the disease. While lung failure is the primary cause for mortality in CF, there really is significant GI morbidity associated with it. And I always tell everyone that CF is really a whole body disease, not a lung disease. And you can see some of the GI complications that are associated with CF here. And central to this is the pancreas. And that's what I'm going to focus on today. And I like to remind people too that almost about 80 years ago now, Dorothy Anderson, a pathologist, was the first to describe CF. And she was studying a cohort of patients children that had celiac disease diagnosis. And she noted that there were abnormalities in their pancreas on autopsy. She noted that there was dilated ducts and that there was marked fibrosis. And then in some of the older infants, she also noted that there were similar pathological features in the airways. And so she was the first to describe CF. And you can see in the panel in the A and B some pictures of some of the children with CF at that time who are obviously significantly malnourished. And this is what CF looked like during this time. Luckily, today in the US, more of our CF children look like the child in panel C. But that's not true in every country. Not every country identifies CF early, and so there's still a significant number of children that die early because of malnutrition. So CF is a rare disease, but I also tell people that it's common enough that most people know someone that has had it. The incidence in the US is about 30,000 people, and it's about 70 to 100,000 people worldwide. But the prevalence really does vary based on the racial and ethnic background of the individuals. The highest incidence occurs in Caucasians of Northern European descent, which is about 1 in 3,000 live births. And CF is caused by gene mutations in the cystic fibrosis transmembrane conductance regulator, a very long name that we refer to as CFTR. And the CFTR ion channel gene was identified in 1989 through a joint effort between the labs of Francis Collins and Lap Chi Choi. And here's just the news and comment that came from the Science Journal in 1989. This really did transform our understanding and how we could study CF. It was that same year that Paul Quinton in 1989 described some of the functional defects in CF, and he described in a sweat gland as chloride secretory dysfunction. The CFTR is a protein that's present in both epithelial and non-epithelial cells. Although most people are familiar with the epithelial components, I do remind people that it's in cardiac myocytes, it's in neurons, it's in many tissues throughout the body. And as you can see in this cartoon here at the top, that it's a membrane spanning protein. It has a large regulatory domain, that's that big ball in the center, and then it has 2 nucleotide binding domains. And the site for the common mutation that we see in CF, delta F508, occurs in the first nucleotide binding domain. And the regulatory domain has multiple phosphorylation sites that dictate its activity. Now, CFTR, as I alluded to, conducts chloride, but it also conducts bicarbonate. It's really an anion channel, not a chloride channel per se. And I think that this is really highlighted in the pancreas. And in the diagram we have in the bottom left, you can see that in the pancreatic duct, CFTR can really be permeable to chloride or bicarbonate, depending on the intracellular chloride concentration and at different phases within the duct. And as was discussed earlier, in the pancreatic juice, you start off with a very high chloride concentration, but by the time that that pancreatic juice enters the duodenum, you have a very high bicarbonate concentration. So really a reciprocal relationship. So there's coordinated effort between CFTR and what's labeled here as anion exchangers, AE, which then work together to create this large amount of bicarbonate. So I'm going to spend a little bit of time on making the diagnosis of CF. And when I thought about this talk, I thought that many people historically have seen patients, especially in the adults, that were already diagnosed with CF. But with the advent of genetic testing, we're having a lot more people that are being identified even later in life. And so I wanted to spend a little bit of time with this. Most children in the US are diagnosed with CF now by newborn screening, but it's important to note that CF only became universal in newborn screening in the last decade. And it's also important to note that in other countries, CF is not part of newborn screening. So if you have a patient that's older, born outside the country, don't just assume because they're older and they don't come with the diagnosis of CF that they may not have it. There's numerous algorithms for newborn screening for CF, since newborn screening is state dependent. Here's just several examples of that, and with the highlighted one being the most common one, but all involve a combination of serum immunoreactive trypsinogen, and if that's elevated, you may go on to further testing of IRT or DNA sequencing, but ultimately you end up with sweat testing, which has already been mentioned being important for CF. And sweat testing is still really the gold standard, and I showed the values there. This didn't show up well, but and the premise for sweat testing is that in the sweat gland, you normally secrete sodium chloride and isotonic solution, and the goal of CFTR in the sweat gland is to reabsorb that chloride, and so you end up with a hypotonic solution. But in CF, you don't get the reabsorption of chloride, and that's why you have elevated chloride. For your reference, these are the CF Foundation guidelines. I think, again, it's important to note that you not only start down this pathway if you have a positive newborn screening, but also if you have signs or symptoms that are concerning for CF. We've diagnosed kids with CF in our GI clinic. I know adult colleagues who have diagnosed new CF. And so, again, just because you have someone that you're seeing an adult or an older adolescent, don't assume they don't have CF if the symptoms sound like they could be it. Now, with the genetic testing, we've identified over 1,700 gene mutations in CFTR, which is quite daunting. And anyone that's gotten back any of these genetic testing reports can probably attest to that, like, what do I do with all of these variants? What do they mean? One, I would say I've put some resources here that I use on a regular basis. These are websites that are very friendly that you can go to that can talk about what are the phenotypes. But you also have genetic counselors that can help, who have access to the same information. But in generally, CFTR mutations fall into one of 5 classes. And these classes are broken up based on whether they make protein or inadequate protein or how the channel functions. Now, I think understanding people's genetic mutations has become more important in the last few years because we have mutation-specific therapies. So unlike other gene mutations that we have in pancreatitis, where I tell they often ask, and I say, we're going to get gene testing. Okay, well, what are we going to do about it? And I said, well, we don't have gene therapy. And so part of it is understanding the etiology. But for CFTR mutations, we actually now have a medical therapy that targets these mutations. And I think that there's increased discussions about these therapies that are given to CF patients trickling down to those with pancreatitis that have CFTR mutations. So CF really just was classically thought about as a single entity, but there are multiple other entities that I just want to introduce you to. I won't go into all the details, but there's the CRMS, which is CFTR-related metabolic syndrome, for someone that has features similar to CF but don't quite meet criteria. And then there's also CFTR-related disorder, someone that has CFTR mutations, oftentimes heterozygous, and may have chronic pancreatitis. So making the diagnosis, we also have functional testing. So in addition to sweat chloride testing, which is a functional test, one of the oldest functional testing that we have is something called nasal potential difference. And I bring this up because people may hear about it, may read about it, but it's not done at many places. Only a few academic centers do it. But the idea was to try and understand better how CFTR was functioning in situ because of the spectrum of disease. And I won't go through all the details, but essentially in this prep, there's an electrode that's placed along the nasal turbinate, another electrode on the skin for reference, and then in the nose a tube is placed and various sodium and chloride solutions are perfused, and then you measure the potential difference in response to those solutions. A very messy operation, but one that can give some information about actual CFTR function. More recently, you may have heard, and there's different things that are coming out now about the use of rectal biopsies, either using these biopsies directly in Using chambers for intestinal current measurements, or developing organoids, so patient-specific cell cultures that are derived from the intestinal stem cells, and you can perform what's called a forskolin-induced swelling assay. And again, I won't go into details, but I think you're going to start hearing a lot more people talking about these assays, because there are additional tools to really understand how CFTR functions from patients, but also they're being used for drug selection, testing drugs, so we can actually take a patient sample, go into the lab, see how much at baseline their CFTR functions, give the organoids or the tissue drugs to see if they would respond, and then make decisions about whether that patient should go on that therapy. And so this is really getting at personalized therapy. And so I think you're going to see a lot more of this. Getting back to some of the basics for the pancreas and CF, this is what a cross-section of the pancreas would look like in CF, where you have these really dilated ducts with gelatinous material that is causing the obstruction. You have fibrosis and fatty replacement. And again, it's important to note that these are the classic signs when you have someone with severe disease. You can have someone with very mild disease that will have minimal features of this. These are the classic microscopic findings. The images on the right in black and white are from Dorothy Anderson's original paper, and then on the left are a color H&E. And the features that we see are, again, hopefully you can appreciate some of the differences where you have this enlarged ducts that are filled with mucus plugs, and then there's also an enriched eosinophils around that. Andrew gave a great talk on imaging findings, and these are some of the classic findings for imaging in CF, where you get fatty replacements and atrophy, and sometimes calcifications. So exocrine pancreatic insufficiency really is one of the most common complications of CF. Around 85% of children have EPI. The data shows that it may be less in adults, but that may also be historical, and that less people with CF were living into adulthood, and those that did have milder disease and were pancreatic sufficient. Fecal elastase is by and far the most common modality used for the diagnosis of EPI and CF. And I've listed some of the others. We've talked about some of the pitfalls of using fecal elastase. As a pediatric gastroenterologist, I would remind people too that over the course of one's life and at different stages of pancreatic development, the fecal elastase can vary. So that's what you see here in these graphs, is that if you measure the fecal elastase every month for the first year of life, people can have normal, abnormal values. And so I encourage everyone to not just go off a single fecal elastase value, but really to use it in the context of a patient's symptoms. And a person may have extreme pancreatic insufficiency with a normal fecal elastase. Pancreatic enzymes, I gave sort of typical dosing, but really work with your CF dietitian. They're experts in this area, and we form a really good partnership together. The question of whether you should use gastric acid suppression always comes up. And the idea here is that the intestinal pH in CF patients is acidic because of the lack of intestinal and pancreatic bicarbonate secretion. And since pancreatic enzymes only work at pH above 5.5, then the gastric acid suppression can help improve those efficacy. But not all patients need to be on gastric acid suppression. So again, patient-specific therapy. Pancreatitis is a complication in CF. Typically, it's occurred in pancreatic sufficient patients, and the pathophysiology is there, which we've heard a little bit of already. Interestingly, it's important to note that really the risk for pancreatitis comes down to how much CFTR function you have. And so if you have very little CFTR function, really the risk is very low, but as you sort of get into some more intermediate ranges, then that risk goes up. Pancreatic cystosis is another complication that we see in CF, and it occurs about 8% of CF patients. And this is where you have the multiple cysts of various sizes that fill the parenchyma. It's characterized by a very thin-walled sac that doesn't enhance on imaging, which is different than neoplastic cysts. There's a nice algorithm here that I reproduced that Keith Oy and Jay Freeman put together in the Journal of Cystic Fibrosis. And really it comes down to, are these patients symptomatic or not? If they're not symptomatic, you don't need to do anything about them. If they are, you do, but you do need to keep an eye on them to make sure that they don't become symptomatic. All in all, I would say the future for CF is bright. You can see on the bottom there the median predicted survival age over time, and where back in the late 80s to early 90s, we were in the low 28s. Now we're above the 40s, approaching the mid 40s, and that's only going to continue to increase. It's predicted that kids born today, if this advancement continues, will live into their 70s, which is an amazing thought to think back to what Dorothy Anderson was first describing. And part of that's due to the CFTR modulators. I'm not going to go into detail because of time about how they work, but I've listed them here. The first three are from a single company, but they started in 2012, and they've really transformed how we approach CF. And other modulators are in development. And I just want to end by, again, showing this graph that you need to think about that we may have some increasing complications of pancreatitis in CF patients who are on these drugs because they're actually getting more CFTR function. And there are case reports out there where kids with extreme pancreatic insufficiency, never had pancreatitis, start these drugs, they get improvement in their CFTR function, and that's great. Their mortality is decreasing, but their pancreatitis risk thing goes up. So something to remember, and I'll end there.